Good evening. So I've been asked to rush through anisocoria because of lack of time. So anisocoria is a condition characterized by unequal pupil size, and the pupil is controlled by two muscles, sphincter pupillae and the dilator pupillae. Sphincter pupillae is supplied by the parasympathetic system, whereas the dilator pupillae is supplied by the sympathetic system. So we'll skip all this. And we have to ask a thorough clinical history. Should ask for history of eye trauma, surgery, use of eye drops, tumor, or any surgery in chest and neck. And ocular examination is very important. We should check visual acuity both for distance and for near eyelid position, extraocular movements, pupil sizes in light and dark, pupil light reaction, and should check near reflex, spinning flashlight test, and a thorough slit lamp examination. First, we should rule out the conditions, ocular conditions causing anisocoria, like tears in the pupillary margin. Should rule out signs of any intraocular inflammation or signs of acute angle closure, glaucoma. And the first and most important thing is first rule out physiological anisocoria, because that's the most common thing that we see in our OPD. So 15 to 13% of the population can have physiological anisocoria. And here we should know that the difference in pupil size remains equal in dim and bright lights, and pupil constricts to light and dilate in dark equally. Usually the size discrepancy is less than 1 millimeter. So we should identify which pupil is abnormal. If anisocoria is greater in bright light, it means that the larger pupil is abnormal. If anisocoria is greater in dark, it means that the smaller pupil is abnormal. So this is the flow chart which will help you diagnose the cause of anisocoria. So if anisocoria is more in the dark room, so we should check for dilation lag, and we should consider 0.5% or 1% apraclonidine test, and consider 10% cocaine test. And if there's no dilatation lag and dilation occurs with 10% cocaine, it could be physiological anisocoria. If dilation lag of smaller pupil is present, and if there is reversal of anisocoria with 0.5% or 1% apraclonidine, and dilation does not occur with 10% cocaine, it could be Horner syndrome. Once we diagnose Horner syndrome, we have to localize the lesion. We have to do hydroxyamphetamine test, or we can also do 1% phenylephrine test to know whether it is preganglionic or postganglionic Horner's. Next, when we find anisocoria more in the bright room, we should do careful slit lamp examination, check for near constriction, and consider 0.125% pilocarpine test. If there is torn pupillary border with sluggish near constriction, it could be traumatic iris damage. If the pupil is round and there is poor near constriction and no constriction happens with diluted pilocarpine, we can do pilocarpine 1% test. And if constriction occurs with 1% pilocarpine, it could be Turner palsy. If the constriction does not occur with 1% pilocarpine, it could be pharmacological pupil dilation. And if we find sectoral iris palsy and wormiform movements on slit lamp examination, and if there is tonic near constriction, and if constriction occurs with diluted pilocarpine, we come to the diagnosis of Ades pupil. So we'll just see some pictures. So this is a case of Ades pupil. You can see here there's light-noise dissociation. It's not reacting to light, whereas with near target, we can see constriction of the left pupil. So for, as I discussed before, so for Ades, we have to do diluted pilocarpine testing. So if the abnormal pupil constricts, it means that Ades pupil is present. So here you can see tears in the iris sphincter. And this is Urid-Zavarius syndrome, where there's fixed dilated pupil following ocular surgery. So we'll see a few tests in Horner syndrome. So as I discussed before, if dilation lag is present, it means it is Horner syndrome. So what is dilation lag? So we can see in this picture, when the lights are off in the normal eye, we can see the pupil dilates immediately. Whereas in the affected eye, after the lights are switched off, the pupil dilates slowly due to relaxation of the sphincter muscle. And after 15 seconds, it catches up with the dilation of the fellow eye. So we can skip the video. So this is the basics of pharmacological testing. So normally norepinephrine is released from the terminal axon into the synaptic cleft, and it binds to the postsynaptic cell membrane, and it causes activation of the iris dilator muscle and molars muscle. Whereas in Horner's, as there's no oculosympathetic activation, there's no release of norepinephrine into the synaptic cleft, and this lack of stimulation leads to upregulation of the postsynaptic receptors for norepinephrine. So when we do a cocaine test, it can be either 4% or 10% test. When we put in the affected eye, there is no change. Whereas in the normal eye, we can see the pupil dilates. So coming to hydroxyamphetamine test, it helps to localize the lesion. If there is bilateral pupil dilation, it could be first or second order neuron lesion. If the horny pupil fails to dilate, it could be third order neuron lesion. So this is the summary of the pharmacological testing for Horner. It can be very useful for the postgraduates. So for diagnosis, we can use either cocaine 4% or 10% test or appliconidin 0.5% or 1% test. For localization, we can use either hydroxyamphetamine 1% or 1% phenylephrine test. So as the earlier speakers discussed, acute painful Horner is an emergency. So we need to do CT angiography or MRA with MRA of head and neck when we suspect carotid dissection. When there's a non-acute Horner with no localizing signs, then we have to do contrast enhanced MRI with or without MRA, including brain and neck, from hypothalamus to T2 level in chest. So again, this is the anisocoria algorithm. So we have to check if anisocoria is greater in bright light or in dim light. If it is greater in bright light, it means the larger pupil is abnormal. And if the patient has ptosis and EOM restriction, it could be a third nerve palsy. If there is full motility with no ptosis, when we also see segmental constriction and light nerve dissociation, it could be tonic pupil. And we have to do diluted pilocarpine test to confirm it. And if we suspect pharmacological dilatation, then we can do 1% pilocarpine test. It will not constrict with 1% pilocarpine in case of pharmacological mydriasis. If constriction occurs, we can reconsider third nerve palsy. And if the anisocoria is greater in the dark, it means that the smaller pupil is abnormal. We have to do upper or cocaine test to confirm Horner syndrome. And once Horner syndrome is confirmed, we have to do hydroxyamphetamine test or 1% phenylephrine test to localize the lesion. If we suspect Horner syndrome, it is important to do MRA brain, neck, chest, and abdomen to cover the entire sympathetic chain. If it is Horner in adults, it is important to do MRI with MRA of the brain, neck, and upper chest. Thank you. I'd like to thank Dr. Balraj sir and Dr. Venkatesh sir for giving me this opportunity. Thank you.